Thanks for joining us today in our ST3 General Surgery interview preparation webinar. First of all, I would like to thank Mr. Nazar, Essa, Mr. Ajit, Oberoi for joining us today, for their time and effort, and for helping us with this webinar. To start, this webinar is going to be divided in two parts. First part is that we're going to give you an idea of the recent change. It's about to talk about the changes in the interviews format in the recent years and how to answer the questions to get the highest marks, we hope. And then the second part of it will give you some scenarios, and so we can give you some feedback, and tell you how to get the best of your station. So for this part of the session today, we would like some volunteers from you. So if you would like to volunteer for one of the sessions, please write your name in the chat now. So, and when we reach this point, we'll choose from these names. To remind you, this whole webinar will be recorded, and we'll put the video later on our YouTube channel. So I'll ask you for a couple of things. First, that after the session, we will send you a feedback form. So please help us improve these sessions by responding to them. It will help the instructors or the presenters as well. And in the same email will send you the dates for the coming sessions. The coming sessions is not going to be recorded or anything. It will be a weekly session in the weekend with one or two instructors. But of course, we encourage you and we recommend that you make groups and practice between each other during the week. If you have any questions, please put them on the chat as well. I'll ask you all to mute yourself. We'll try our best to respond to your questions today. So now, again, I'm going to welcome our two instructors today. I'll let them introduce themselves and start the session. And thank you all.
Thank you very much,
Nazar and Ajit. Yeah.
You're welcome. Thank you, Amira, for the nice presentation and giving us the opportunity today to speak about insights and tips and tricks about ST3 preparation for general surgery. Excuse me. So I'm Nazar Essa. I'm a CCRISP instructor and have been coaching a candidate for this interview, especially the online version over the last 3 years. And that's why I thought I would contribute for this webinar. And hopefully the people can benefit from it and find it beneficial. Ajit, do you want to introduce yourself?
Hello, everyone. Thank you, Nazar, for this opportunity. I think last time I was on the other side of the table. And thank you for this. I think I'm one of the ST3s in west of Scotland. So I thought this is a good opportunity to give it back to from the society, which I benefited from last time. Hopefully this session would be very useful for everyone, and we can share our experiences from the last time and the new changes which have come.
I just want to add, one more thing before you start. I know that this is, we're using Teams, so sometimes it limits the meeting to 1 hour. So if it disconnects by the end of the hour, I'll put you another link in the chat so you can just use it for the next session. All right. Sorry again. Thanks.
No, that's fine. Yeah. So, as Amira said, this webinar will be in two sections or 2 parts. The first one will just give brief talk about the interview, the most up-to-date, and we'll speak about different stations, and in between we will stop for questions and your thought as well. So we'll start by speaking about the interview format and the update. And we speak about the clinical scenario station, and how to answer the clinical scenario, and then management scenario as well, portfolio. And then at the end, tips and tricks for preparation. And then we'll start the next part, or the second part of the webinar, which is a mock interview. The interview time is 40 minutes, divided into 3 sections. The first one is the clinical station, which is 15 minutes. The initial or the first 5 minutes will be reading time, where you will see the clinical scenario on the screen. And then after 5 minutes, you will start answering straight away your clinical scenario. And then same will be for the management station, 5 minutes to read and 10 minutes to answer. And this is definitely better than the before. Before they used to give you both scenarios reading time together, and then they ask you to answer both of them in 20 minutes, 10 minutes, 10 minutes. This is, I think, more convenient for everyone to have reading time, answer scenario, and another reading time and answer the management scenario, and then the portfolio station, which is 10 minutes. Let's speak about the clinical scenario. First of all, it's very important for you guys to understand what type of scenarios you should expect. I categorize them into 3. Either your scenario will be about polytrauma or acute abdomen, either acute abdomen with sepsis, acute abdomen with no sepsis, like pancreatitis, for example. And recently, we start to see vascular emergencies, like last year, where the scenario was about pseudoaneurysm, for example. And I believe the reason for that, the general surgery trainees, they sometimes, especially in district hospital, they cover both vascular and general surgery, and that's why I think they are touching on this type of scenarios. Most of the time, it is a complicated acute scenario where there will be more than one case in the scenario. But I will speak about this later. Will be only one scenario in the main case in the scenario, and subsequent questions will be about this case, not the other. The other is just to make it more challenging. Always in management scenario or in the clinical scenario, there will be both component, because the management scenario will be in a clinical environment or background. That's why it's very important that you understand or to remind yourself what station you are doing right now. If it is clinical, then you don't need to go into much details about the management aspect of the scenario. And if you are doing management scenario, don't go into much details about the clinical scenario. This one of the important things about the clinical scenario, especially that the scenario we see in reading time is actually the initial scenario most of the time. Last year, that was the case. It's just one scenario, and that's it. But in the year before, there will be a hidden part of the scenario written in front of the examiner, which I used to call it the escalation of scenario. So you will see the initial scenario, and then you will speak about all the steps until you reach the moment where you will say, I'm taking this patient, for example, for laparotomy to do right hemicolectomy. And that should be the end. And then you will see the examiner start to give you another situation, make it more challenging, in saying, for example, you came to do the ward round on day 5. And the nurse in charge asks you to review this patient because he's tachypneic with high inflammatory markers. And this is what we call the scenario escalation. So my advice to you is try to make your answer for the scenario written in front of you in, I would say, not more than 8 minutes. Just in case if there is escalation, you will have time. Because I believe all of the candidates, they will be fantastic in doing the clinical station and sorting out the initial scenario. What will set you out of the crowd and give you higher mark is the next part of the scenario, which is the escalation, where the people, this is what I have seen from the feedback I see with my candidates over the last years. So most of the examiners' feedback about the escalation, that for example, the patient deteriorated and the candidate was not able to tell what the reason of the deterioration, as you will see from the feedback I will show you to you recently. or soon, sorry. In regard to the reading time, I will advise every one of you to have pen and paper to write down. It's very important, I think, especially during stressful situation, to remind yourself, at least if you manage to write the issues, then the rest of it will be fine because you are practicing every day answering with a very unique structure or framework you are using every day. It's very important to have full situational awareness. And I think this is what will make you very successful in this station. And what I mean by situational awareness is one of the non-technical skills now people start to teaching surgeons about it. You know, there is a very famous course run by the Royal College of Edinburgh. We call the NOTS course. It's very important. And they speak about the non-technical skills that the surgeon need to improve his outcome. And the first skill we need to learn is situational awareness, which is basically to understand the information in front of you and comprehend this information and try to understand the projection of this information on the future and then plan what will be your actions. And this will come by answering 3 questions. The first question is what? Second question is so what? And the third question is now what? And just to make it simple, if the scenario, for example, saying the patient is known to have atrial fibrillation on warfarin, this piece of information, this is what. Now, your next question will be, and so what? What will be the projection of this problem on the scenario and on my answer and plan of action? Definitely, you will face high risk. You will face a risk of bleeding in the operation, especially if you are taking this patient for laparotomy, for example. And then now what will be, what's your action? And that's where you will say, I will reverse, or I will speak to the hematology, take their advice on, and so on. So it's always better to approach your reading time, asking, assessing the scenario in this way, so you have full situation awareness about the case. I said get the main case right, and I think this is very important. As I said, the type of scenarios we should expect is more than one patient, most of them unwell, but there will be one case that the examiner got, for example, a CT report about it, and he got questions ready for you to answer. And if you ask me what will be the hints to say this is the main case in the scenario, for example, let's say that the scenario is saying there is a 47 years old man, diabetic patient with perianal abscess awaiting incision and drainage. And there is a 35 years old young lady with CT proven appendicitis awaiting laparoscopic cholecystectomy. And there is a 72 years old man with severe epigastric pain in A&E was not seen by your colleague. So if you got the case with a clear plan of management, like for example, perianal abscess, incision and drainage, this is definitely not the main case. Appendicitis, appendicectomy, this is not the case. The one with you are uncertain about what will be the diagnosis and what is the management, this most likely will be the main case. Number 2, the other hint is the case where they will give you more information, blood test, observations, all stuff, this will be your main case. Because the last thing you want to do is to start with other than the main case, and then the examiners will try to stop you and push you back to go to the main case in scenario. So take your time and make sure that you got it right. List and categorize the issues. Definitely, every one of you has his own frame of answer, structure of answer. I will suggest one frame here, but definitely you feel free to use anyone. At least the frame you are using should cover all the 4 domains, as I will show you now, 4 domains that examiners are looking for. So always list and categorize, because signposting is very important. I used to say the issue should be listed into clinical issues, other clinical issues, and managerial or organizational issues. And as I will show you, I suggest to use SIPs as a frame for answering the clinical scenario. But there are different frames and structure out there. You can use anyone. Just make sure that the structure you are using will cover all the 4 domains that the examiners will assess you and give you score on. During the reading time, make sure that you make yourself aware and list all the teams you want to involve in the care of your patient. Now, there are 4 domains in the examiner score sheet. This is from 2024, the last interview. The first one is a recognition of issues and situational awareness. And the second one is prioritization, planning and use of investigation and resources, and finally, communication strategy. You will see 2 examiners in the station, and every examiner will give you a score out of 5. One will be if your performance is very poor, 2 for if there is area of concern, if it's satisfactory 3, and then good 4, and excellent 5. And then they will add the 2 scores together. So your final score in each of these domain will be out of 10. So the final score of the station will be out of 40. Now let me introduce to you SIPs, which I feel like is more appropriate to cover all these 4 domains. So S for statement, make introduction, I for issues, and then priority and time scale, and strategy and communication. What I mean by statement is intro. You make it to show the examiners that you have full situational awareness and you understand the complexity and what is this the core of the scenario is about. Is it polytrauma and acute abdomen with sepsis? And it will be in a nutshell. You will show the examiner what are the challenges there. So this is a brief example about what I mean by statement. Now, as I said, the categories of the issues, clinical issues, where you will speak about the top diagnosis for the main case, and you list the differential diagnosis. This will be your first category of issues. And then you will speak about the other clinical issues. Other clinical issues, my advice to you is to look at the blood pressure, observations, and inflammatory markers, and see if the picture is fitting or matching sepsis or no. If you look at the blood test, you can see some sort of AKI there. Look also at the comorbidities and the medical background of the patient and his medication as well. This is exactly where you will see the other clinical issues. The management issues, you need to speak about them. And as I said, because this is clinical scenario station, so you need to speak briefly, and better if you can outline your actions here, because definitely there will be no time for you to come back and speak about the organizational issues. So mention the organizational issues and briefly outline your action here, and then just ignore them. So priorities about telling the examiners who to see first and why, and what about the other, what will be your plan for the other people, and also the time scales you will see and deal with every case. And then in the strategy and communication, actually, there are 3 steps. Always remember, in your strategy, you should divide your actions into 3 phases. The first one is, what do you need to do before attending the patient? And number 2, the second phase is when you arrive and see the patient, what approach you will use. And there are 2, only 2. Either your scenario will be polytrauma, and then the examiner expects you to speak about ATLS approach, or surgically unwell patient, whatever it is, vascular emergencies or acute abdomen with sepsis, acute abdomen with no sepsis, only one approach with the C-CRISP. So be familiar with the ATLS and CCRISP protocols. And then we'll speak about the communication. So before attending the patient, sometimes there are few things you need to do. For example, gather more information. If the patient is coming from different hospital, you need to ask about expected time of arrival, for example. Ask, for example, the A&E, if they are saying the patient in waiting area, ask them, for example, to move this patient to monitor area. And sometimes if the scenario is saying the patient is repeatedly vomiting, then you ask for, can we insert NG tube? And the aim is to prevent aspiration pneumonia until you see the patient. Also, if there is a language barrier, you can ask for interpreter as well. Also, you will tell the examiner that how you are going to organize your team, because sometimes you will have one patient they're about to call to come theater, and you want to stop that patient from coming theater by saying, hold on, sending a patient, or you want to do different things at the same time. And here where you show them your leadership and then how you are going to sort out your team. For example, I will ask the SHO to go there, and I will ask the FY1 to go there. So also before attending the patient, you might need to speak to the theater coordinator or the anesthetist or your senior as well, if you feel like this situation is very complex and you need to share with him your thought on, I'm going to see this patient, leave this patient for later on. As I said, hold on and send the patient. So there are few things, and all of these things will come from the situational awareness. When you make yourself fully aware with the scenario and the situation, you will be able to predict what are the things that I need to do before attending your patient. And then, as I said, on arrival, either you will go for ATLS if it is polytrauma, or you go for CCRISP if it is a surgically unwell patient. The last thing is the communication, and always remember your approach should be multidisciplinary approach. So speak about critical outreach team, ITU, theater coordinator, anesthetist, stoma nurse, microbiologist, all these people, you should mention them and don't wait to be prompted to mention them. So in summary, the framework I'm suggesting here is statement, and then the issues, priority, time scale, and the strategy and communication. Then let's speak about the escalation of scenario. The escalation of scenario, like as I said, you will answer the initial scenario, and then the examiner will escalate the situation by one of, I believe, three from my observation is always out of one of these three. Either your patient will deteriorate, like for example, will develop anastomotic leak. You said in the initial scenario, I'm taking him for right hemicolectomy or left hemicolectomy. And then the examiner will show you sign of abdominal tenderness. So he's taking the patient toward the anastomotic leak, and he will ask you what to do. Or just postoperative infection, chest infection, yeah? Or the escalation might be renal, which is the worsening renal functions. To be honest, surgical and respiratory escalation a little bit more common than renal and cardiac escalation. Or this happened 1 or 2 years before, is the escalation was just a communication skills. When they ask at the end of the scenario, ask you to speak to the patient relative, and then they will assess your communication skills. Or it simply can be just follow-up questions about, for example, if the case about perforated diverticulitis, they ask you about classification of diverticulitis, are you aware of any, and all this just clinical question. So my advice to you, if you reach the escalation of scenario, first of all, you don't need to go through the details of the answer again. So don't say like the CCRISP again, because you already said it. You already explained that in your initial answer. So say briefly, I'm going to see this patient, assess him, and restate him simultaneously using the CCRISP algorithm. If the patient is septic, you say, I will ensure sepsis 6 is incorporated in my CCRISP algorithm. And that's it. And then you say, you start the same way. First of all, start with the possibilities or the issues. And clinically, what is the cause of the deterioration? Say the most likely this patient deteriorated because of pneumonia, but I will consider other options or other possibilities, like, for example, a leak or surgical site infection, and you mention all the possibilities. And then on your approach, you say, I will see him immediately, assess him, restate him with CRISP algorithm, make sure to incorporate all the sepsis 6 in my assessment. So you don't need to go in details, because you got maybe 2 or 3 minutes to answer this bit of scenario. And then from there, it's very important to speak about your what you are going to do, CT cap, for example, and then you will say, I will involve this team, and you mention all the MDTs you want to involve. So it's very important to answer briefly, but don't miss anything. And for example, if the escalation surgical deterioration of the patient is surgical, then remember microbiologist, stoma nurse, IR team. If there is a drainable collection, ITU, critical outreach teams, these are the teams you need to involve. If it is respiratory, then chest physician sometimes, ITU, critical outreach team, chest physiotherapist, and microbiologist, very important. Renal, I haven't seen one, but again, nephrologist, hemodialysis nurse, microbiologist, ITU, critical outreach team as well. For the cardiologist, again, hematologist sometimes might come in, and the heart failure nurse, or this. So always remind yourself with the teams you need to involve. Just have a look on this feedback, and I'm grateful to my colleagues during our coaching. They provide me with this feedback. They're saying, like, for example, the examiner wrote on his feedback that the candidate did not consider microbiology input. You see, most likely this in the escalation part, he didn't mention that I will ask the microbiology, because we always tend to say I will start antibiotic. Sometimes if it is complex situation, better to get the microbiologist involved. He said here, good initial assessment, but missed pneumonia at the cause of deterioration. Wasn't paying attention. And he said require prompting to discuss with the chest physiotherapy. You see, if you look at these feedbacks, most of them, I believe, is from the communication and the MDTs. I mean, like the other teams to be involved, because this is something we are like not paying attention to it during our regular practice. Is that we should get use of these teams. He didn't involve the chest physiotherapist and the microbiologist as well. And here needed a prompt to consider requesting imaging, for example. Here, the candidate was very keen to take the patient theater without any images. And here, the case was, I think there was a need for vascular surgeon input, and that was not given by the candidate. Okay, I will stop here, and I will invite my colleague Ajit, if you want to comment, please, on this section, and also we'll see if we got any questions on the chat to answer them.
Thank you, Nazar. I think that was quite an in-depth analysis of the clinical scenario. Then a couple of points which I want to add, which I think many people get anxious on the day of the interview. What really happens before your interview starts? So what usually happens is you will get a link for the interview, a unique link for your interview after you get shortlisted. Hopefully, all of you will get shortlisted. And on the day of on the day of the interview, you will be asked to log in a couple of minutes just before your time. You will be in a lounge. You won't be seeing anyone. There would be probably a one official who will just have a wee chat with you, and they will ask you to just show the room in which you are sitting. So I think it is very important that you are in decent clothes, at least the top, and show the room all around, and it's not messy. There's no one in the room. You have a stable net, and they will check for your identity documents, usually passport, and then you will be just waiting in the lounge. And after that, you will start with one of the scenarios, which it is not always that you start with the clinical scenario and go to management and go to portfolio. It's not like that. You will have a slot in which you will be told that, okay, you are probably starting from a portfolio scenario, and then you're going to management and clinical. So just don't fix your mind that you'll all start with clinical scenarios. Other thing is that regarding the vascular scenario, I think Nazar pointed out rightly that sometimes in small DGH, you are supposed to see at least do the initial assessment of these patients. So don't get anxious that they're not going to go in details of AAA management, acute limb ischemias, or a couple of these important pseudoaneurysm ruptures and things like that. But what they want from you is that you in do an appropriate assessment, resuscitation, and escalate timely. I think that is what they are. They don't want you to repair AAA as an ST3, but they want you to identify it, diagnose it, and call the vascular surgeons. And usually these scenarios will have another general surgery scenario associated with that, like something you are going to do an appendix and there is a AAA in emergency. So they are also usually testing your management skills in this scenario. So you're calling your general surgery consultant to come and do the appendix. In the meantime, you are attending on a AAA. Second thing is, Nazar rightly pointed out that these days scenarios are not purely clinical or purely management. Like both the scenarios which I got and my colleagues got, they had a mix of both management and clinical. So it is really very important that you address that just at the start of the scenario when you're going through your SIPs, because you will not get time to come back. I can guarantee you. And those 5 minutes when you are reading the scenario, when you're practicing it, make sure that you have, like when you're practicing, just keep in mind that you have only 4 minutes, because I can tell you on the day of the interview, you will fumble, you will panic, you will have a cold feet, you won't be able to focus as much as you can do on your normal day. So practice for 4 minutes so that on the day of the interview, you can, you can be very slick. Uh, Time really passes very quickly. The scenarios are big. Okay, I know we all do. There are a couple of famous resources which we do, but I think that sends out a wrong impression in our minds that there will be 4 lines or 5 lines at max in the interviews. No, they are big. They are big scenarios. You can't like the 5 minutes will just pass like this. And I think when we are doing scenarios today, I have a couple of those long scenarios, so might give you a taste of that. One thing is you see only the slides during your 5 minutes, okay? And you don't see any of the interviewers when you are seeing the slides. So it's you and the scenario. And after the 5 minutes, doing whole of the interview, you do have a timer on the screen. Okay, so because that is one of the things which also makes us anxious. So there will be a timer, and I think there is a there's a pop up also when 30 seconds or 1 minute or 2 minutes is left. Uh, and when the interview starts, the interview and you will be there. There won't be scenario, and they will ask you if you have read the scenario or you want to read it again. Mind it, if you say no, I want to read the scenario again, you can do that. In fact, I think there is a way to see the scenario again. But the problem is you have only 10 minutes. Okay, all that time will be deducted from your 10 minutes. So you take 20 minutes to reach your scenario, doesn't matter. Will have only 10 minutes with the interviewer in which they need to assess you. And it is very important from the starting when they give you an open platform, that usually it will be like, okay, how do you want to manage this scenario? So it is very important that you uh, say everything which you wish to, including your communication, because that is what we usually miss out on, involving ITU, family, nephrology, microbiology, pulmonology, whatever you want to say. Because what happens is if they prompt you, your marks get deducted. So prompting reduces your marks, that is for sure. So if you can say it in one go, everything which you want to say, it will grasp you the maximum marks. Last year, most of the escalation, as Nazar told, was based on your communication skills. All of the people which I know were asked to assume that the interviewer is in a consultant and to inform him about the scenario, or about the situation. And this will usually happen at 7 or 8 minutes when you have said everything you wish to say. And then they might escalate or they might not escalate. Also, when they are telling you the scenario, they might be just a stem of the scenario, and they might show you images or reports as and when you ask for them. So suppose you say, okay, no, I want to do, this is a patient with probably small bowel obstruction, and I want to do a CT scan. Then they will pop up a picture with a CT scan with a report, or very obvious dilated bowels, and they might ask you what next. So this can also happen. This might there might be a hidden second stem, second part of the main question. Situational awareness, which Nazar told, is very important, and it is very important that at the start only you say that this is an acute situation where this patient needs urgent, if this is an urgent scenario, obviously, and most of them will be urgent, to be honest. So if you say that, okay, this needs urgent reviewing and probably urgent theater, then they know that you understand the urgency of the situation, and you are prompt to act. This was one thing which I did not do it in my interview, and I got punished for that, honestly speaking. Uh, Regarding CRISP and ATLS, I think apart from this, it is also important to say about sepsis 6, because most of these patients would be in sepsis 6. So it is always a good practice to say that I will manage this patient as per CRISP protocol and sepsis 6 protocol. Why I'm saying is because you might not say all the components of these both protocols, but the interview knows, okay, that it is in your mind to do full set of sepsis 6 and sepsis 6 bundle and CRISP. Also, one question which we always tend to do wrong is when we say that, okay, I'm going to do this patient, manage this patient as CRISP or sepsis 6, we start going through all the components of CRISP, which is not at all expected at you at ST3 level. That is more of a core trainee level. At your level, what you are required to say is that, okay, I will manage this patient as CRISP protocol and sepsis 6, ensuring the points which you think are relevant to this patient. Suppose there's a patient with, obstruction, but he's speaking patient. So you just need to say, okay, I need to manage this patient as CRISP protocol in an A to E manner, making sure airway is fine. This patient probably, or you will say that, okay, the blood pressure is low. It will be on your screen, or it will be on the scenario. So you need to say this patient has low blood pressure, needs a cannula, needs the bloods, including this. Very crisp. You are not going to say each and every component of a crisp protocol, because then you will just spend 5 minutes, 6 minutes saying that. And then you will not be able to focus on other important components of the question. I think, yes, that is all what I wanted to add. Yeah, thank you.
Thank you so much. This is a very important point. Thank you so much. Before I go to, I don't see any question here, so I will go for the management station. But before that, you just remind me with a very quick point, which is about the emergency number. They will give you emergency number in case if you lost the line and the contact. My advice to you is to write it down on paper, and on the day of interview, better to put the your phone and not switched off, but go get it in airplane maybe setting, just to be accessible for you to call them urgently and quickly if you got any concern. I see there are few hands here. Rizwana.
Hello, hi.
Hiya.
Hi, I have just one query. That is, if we say that the patient is CT abdomen and pelvis, and the CT abdomen and pelvis show perforation of the gas-containing hollow viscous, so that the patient is surgery, we know. So after the CT report, should we escalate this to consultant, or should we talk to the patient first? Which one first, patient or the consultant?
That's a very good question. You don't want to have any conflict with your consultant plan, because sometimes you might operate, your consultant might need to conserve, especially if, like, for example, there is a frail patient, high-risk patient, and I think the sequences should be, you will update your consultant with the CT finding report, and you will update your consultant as we do in a form of a SPAR. where you don't want spoon feeding from your consultant. You will recommend to your consultant, I'm talking to, or I want to speak to you about a lady, I think she need to go for laparotomy, and this is the CT scan finding. And then you make sure that you and your consultant on the same page. And then your next step will be, before speaking to the patient, is to get the NILA score if you are doing laparotomy. Yeah. And because the NILA score will inform you and will inform your patient as well, to tell him about the risk of mortality. And then from there, you go and speak to the patient.
Okay.
That answer your question?
Yeah, thank you.
Lovely. Who else? No further question. Okay, Jenny. No, Jenny. You want to?
Yeah. Should we do the NILA scoring before we speak to the consultant?
Yeah, that will inform you and your consultant as well. Yeah, no debate. You can do it, but what I want to say is, don't go to the patient before the NILA, because you will speak to the patient and tell him exactly this is the high risk operation. Then that doesn't make sense to the patient. He won't like figure, want numbers, so he can formulate his decision as well.
Thank you.
Okay, lovely.
I think there is a question from Mohammed.
Sorry, Mohammed.
Hi, my only question is that, since the time is the key, once we read the whole scenario before discussing our management plan and situation awareness, do we have to summarize the whole scenario again in front of consultant?
You want to comment on that, Ajit?
So what you are required is to process that information and highlight the issues rather than just repeating the scenario. Okay, so like if there's a scenario with a patient abdominal pain, and they've given you the picture that patient is looking a septic, hypseptic shock, and then patient they will not tell you that patient is in septic shock, but they will just give you figures. Okay, that blood pressure is 90/60, temperature 39.2, and the bloods are back, which is white cells, crazy white cells, and CRP out of the roof, and things like that. So what you need to tell them is not that, okay, this patient is hypertensive and things like that. You need to tell, okay, this is a 69-year-old gentleman who I think is having acute abdomen. Patient is in septic shock and would need assessment as per CRISP protocol and sepsis 6, involving a CT scan and management based on that. That is what they want from you, an outline of the clinical issue which you have assessed, and a basic plan. But they don't want you to repeat the scenario. And anyways, if you do that, that will just waste your own time.
Thank you.
Lovely. We'll go to the management now. Okay, so the management scenarios, if you ask me what type of scenarios we should expect, then I categorize them into, I believe, 7 categories. Your scenario might be about logbook dilemmas, might be about handover dilemmas, might be about outpatient clinic, or surgical never events, theater list dilemma as well, training surface imbalance, and the last category is the underperforming team. And most of the time, because they will make it a little bit complex, they will make more than one category in one scenario. For example, you have logbook dilemma and then training and surface imbalance in the same scenario. Yeah. So it's very important, while you're practicing with your colleague, is to make a structure of or plan of action, what to do in case of logbook dilemmas, what to do if your case is about outpatient busy clinic where the consultant left you alone to deal with very complex cases, and what will be your approach. And we will speak about how to answer, but these very important things, you should be ready to deal with them. Surgical never events, what are the things that you should do here? For example, what are the surgical never events? You should have idea about this. Go through the list on their website and try to understand what is considered as a surgical never events. Because now, very important thing about the management scenario station is buzzwords. they want you to use these terms. Like if someone said, oh, this is something's not accepted, but other candidates said, this is the surgical nerve event, this completely different candidates. One of them is fully aware about the setup in the NHS and the thinking of using the terms will tell the examiner that you are someone who used to deal with management aspects in his daily practice. So, so there will be a frame to deal with. For example, let me speak about surgical nerve events quickly. So someone came with right axillary abscess, and your colleague drained, for example, on the other side. And you came to start your shift, and the nurse asked you to review this patient. He's quite unhappy. He said the site of his previous swelling, painful swelling is still there, and he see the dressing on the different side than what he thought. And then you go there and discover the abscess is still there and your colleague operated on the other side. So what will be your approach for this situation? So there are few concepts you should apply here. For example, there is a concept of duty of conduct, first of all, and you got another concept which we call the Swiss cheese principle. If you think about that your colleague alone will be blamed for this never event, then you missed the scenario, because if you apply that principle of the Swiss cheese slides, then you will think about the surgeons who consented the patient and marked him. This is the failure at this level. And then the nurse of the ward, which check the consent and give the patient to the theater porter. And then the sign-in process is starting from the anesthetic ODB who did the sign-in and the anesthetist. And also during the time out where everyone shouted the holy checklist. And then also after the patient came out on the sign out. So time out and sign out, all these layers failure. So it's not only the surgeon who did the operation, but there are many layers and the mistakes happen in different levels. That's why the patient got the wrong side operated on. So this will be your approach and this will be your understanding. Other candidate who is not familiar with this and he didn't practice this type of scenarios, he will just say, I'm going to speak to my colleague and explain to him what he did and try to understand what was the, and gather more information. No, there are few concepts you should apply here, as we said, duty of conduct, and then you will speak about this principle of the Swiss cheese principle, and you will speak about the root cause analysis. So it's very important, guys, during your practice is to take one scenario from these themes and try to make a plan of action ready for each one. Again, there are 4 domains you will be assessed on: recognition of issues and situational awareness. And this is the score, the up-to-date component from 2024. And prioritization as well, communication, strategy, content, and team working and solution. And again, the score, each consultant will give you out of 5, and then your final score in each domain will be out of 10, and the final score of this station will be out of 40. So what I will recommend here is to use SIPs again. Start with the statement, as we said before, and list your issues. And again, I will remind you, this is the management scenario, so speak about the clinical issues briefly here, and you will not get any time to speak about them later on. And don't go into much details. Priority, determine what patient you will see and what will be the time scale of your strategy. Now, the most important thing about the management answer is your answer should be divided into 2 prospects: the short term and the long term. The short term is to save the day, what you are going to do today. Yeah. And you should mention what your expected outcomes from what you have done and what are the challenges and what will be your alternative plan if what you are hoping for didn't happen. This is all in the short term. And then you will speak about the long term. And this basically, the long term is about preventing this situation from happening again, either to yourself or to other trainees. And here where you will come with the smart ideas, quality projects. You might think of making pathway of care for this situation, and you think about how to improve the care in your department. And this bit is very important, and this is where the examiner will be amazed by what you are saying, and most likely will give you more score if you came with good ideas about how to improve service in your department. Be familiar with this terms, as we mentioned, root cause analysis with this model, duty of conduct, dialectics and never event, escalation of pathways. Very important to know the trainees, what will be the escalation, who to contact first, and who will be your next step. And also get use of these agencies like patient advice and liaison service we call PALS. And if, for example, your case is about Jehovah's Witness, also the Jehovah's Witness Committee and representative, they will help you as well. So get yourself familiar with this and make sure you understand where and when to use them. And again, just have a look on this feedback from the management scenario given to the candidates before. The first one said, did not mention utilizing the skills of colleagues such as the colorector, CNS colorector nurses. No apologies were offered to the patient, required multiple prompts for consultant and senior help. So it looks like this one has seen a CT scan, it's not been reported yet. So he made the report and he said he will tell the patient that they deliver metastasis, although there was no official report, but radiologist. So he didn't escalate here as well. And this is the last one, did not signpost to the pulse. So the patient had a most likely either never event or something like that. And the candidate didn't mention that I will offer the patient to contact or the contact details for the pulse. Lovely. We'll stop here again and ask Ajit if you want to comment as well. And we'll see if we've got questions. Thank you.
Yeah, I think that was pretty much standard, the scenarios which you can expect. I think one thing we missed was difficult colleagues. You might have, an SHO who you think is probably not up to the mark, or is not performing optimally, or are difficult colleagues which we use, which all of us have faced in our work side. Also, you need to know about escalation pathway in terms of if there's something you see you feel is not wrong, is not right, so you need to escalate regarding your discussion with clinical supervisor, escalation education supervisor, deanery, and so on. So you need to be very clear about that escalation pathway. Also, complaints regarding the complaints, signposting to PALs and things like that is very important. And what my key has been to manage the management scenarios is I always try to bring some audit or quality improvement, or all these keywords somehow. Okay, I think it is always right when you are practicing these scenarios. Think about any audits and quality improvement projects, or what you can do. We can just list it down on a page. These are the possibilities, because there'll be only limited scenarios, only 10-15 of them, which will come in different combinations. So they just want you to say these words and suggest an audit or things like that. Okay, I want to add it, suppose, or audit how many wrong referrals we get. So a quality improvement project that gives you a lot of marks. If you don't say, obviously you'll be punished. Again, in this, the escalation, as they last year in this scenario, there was an escalation, either discussion with consultant, or discussion with another staff member, or discussion with the patient about a difficult patient. So this was there in the last year as well. So these scenarios also involve escalation. And yes, I think that's pretty much I want to say about this scenario.
Thank you so much, Ajit. So there are questions in the chat. They are asking about the short-term actions. So the short-term action depends on the scenario. So there is no like one actions you will do for each scenario. For example, that's why I need to give you example just to make it clear. If the scenario, for example, saying you are in, let's say you are dealing with colonoscopy list, okay? and one of your patient had a language problem, and another patient is coming for a colonoscopy but had a unwell vomiting and got abdominal pain. And another patient coming for the colonoscopy, and the patient is very anxious and want the colonoscopy to be done under general anesthesia. Okay, so let's just take these three examples. So one with the language barrier, and the other one is unwell, and he will not be able to have the colonoscopy today. And the third one, for example, is someone who is anxious asking for the colonoscopy to be done under general anesthesia. Then your short action will be, you need to be very careful about your prioritization here. Which one of the three you need to see first? So always, guys, if the scenario said unwell patient, this is always priority. So I will say I will go for that unwell patient who is coming for colonoscopy, and you show the examiner that you will go and assess the patient and see if the patient needs to be moved to the like to be assessed by the on-call team, and most likely need admission. And then the colonoscopy can be done later on other inpatients. So you show him that this is not a patient, I can send him home. Yeah. And for the language barrier, you will start speaking about, you will ask the in charge, the colonoscopy, for example, in charge nurse to get the interpreter on the line to help and do it as online rather than face-to-face. And this one of the things that you will sort it at a long term later on. But at the short term, you need to get the interpreter online and see if someone can speak. Be careful about saying, I will ask if one of my colleagues can speak the same language, because I might be from the same nationality of the patient, but I'm not an official interpreter. So that's very important. And also sometimes they might make it a little bit tricky by saying the patient came in with his brother or his mother and they're speaking very good English. And they want you to say, okay, I can speak to them. But the problem is they might not be good at understanding the medical terms, and that's not safe. So don't use them for interpretation. Yeah, and then you will speak about the third patient by having some sort of root cause analysis. Why this patient is asking for the procedure to be under general anesthesia? Because sometimes they might just have not good understanding about the procedure. For example, he's coming, for example, for FlexiSig, and he thinks that it will be the same like the last time when he had colonoscopy. And then if you explain to him that this is not a colonoscopy, this is FlexiSig, and the extent that the camera will go to, he might be happy with that and accept the situation. Or if the patient insisting and give very good reason to have it under general anesthesia, then you will think about alternatives. And one of the resources you can use is to see if the anesthetist on seaboard can come and help. And because you say in your priority, I will see this patient, and my priority will be to avoid any cancellation. Okay, but if there is no way to do it under general anesthesia, you apologize to the patient, and then you will start speaking about the long term. The long term, this patient with language barrier should not come unless there is good preparation for someone to be available. So this is one of the things that you need to address. And the patient who came unwell and you admitted to the ward, you need to gather more information about the situation. If there is any missed, is he someone who had a cancer and now perforated, and that because there was a cancellation delay, and then you will speak about the projects, the odyssey you can do to prevent this situation from happening again. I hope I make it clear. There is a question. He said, if consultant consistently making mistakes, is it escalate to ES directly or talk to this consultant for F1 or F2? Is usually talk to them first and then consultant. Yes. So if you got, for example, the scenario saying your consultant is consistently making mistake, it might be a little bit sensitive to speak directly to the consultant. My advice to you is to start with your educational supervisor, your consultant. And the reason is, we expect they will be more expert than you. They will give you more thought and ideas about how to tackle the situation. And if it is about consultant, most likely you will not be appropriate to tackle the situation because the consultant might not accept. But then you need to see who is very close to this consultant and you might speak to. But you will say, first, I will speak to my education supervisor, get his advice. I will ask him, do you think, for example, if we made that, declare that to X, for example, is that going to be helpful? Your education supervisor might be able to help with. For the F1, FY2, yes, you can approach them. But again, very important, I see one of the feedback last year that the examiner wrote that the candidate is very judgmental regarding the FY1. So don't be judgmental. Say, I show your sympathy and empathy with your colleague. Say that I will try to meet with my colleague privately, and I will approach him in a judgmental way and try to gather more information. Always show this aspect and don't show yourself as making judgment about your colleague. He said, how about a colleague or nurse who speak the patient language? Yeah, this is the tricky bit. I'm not sure what you think about that, Ajit. I think as a colleagues, we are not professional because there are people who be trained on that. To be honest, I think I will not use my colleague as an interpreter. I will try my best to get professional one. What do you think, Ajit? Sorry.
I think it depends upon the type of the situation where you are. Suppose you are in a clinic setting where the patient, there is no interpreter, but you think this patient would be, if you want to bring this patient back again, this is unnecessary delay things. So I think you cannot use your colleague, but I think you can use one of the nurses or language line, which I think Rizwana has correctly pointed out, because most of the hospitals now have language lines. So that is the first thing. But you can use your nurses. You can use the nurses. I think you can use that also. But suppose you are in an emergency situation, but you don't have anything. So I think it is very difficult to say what is right or wrong. But in practical world, we do end up using one of our colleagues or one of the nurses who do speak patient's language, and we tend to use them, because if we don't have anyone to talk to them, then how would we assess the patient in emergency situation? So
yeah, lovely. Yeah, as you mentioned, now this is one of the advantages of the COVID, and I think before that, now the interpreter available online, so there are even number for each language, so that should not be an issue. But be careful if it is about consent. If you are consenting the patient, better to get the official and get his name. And if you see your consent form at your trust, you will see there is a place where you will write the name of the interpreter, because it's very important from medical legal point. I will not use my colleague for consent, definitely. There is a question, it said, if the patient is asleep in theater, waiting you to do surgery, and there is unstable patient in ED, and you need to see immediately, and the consultant is far away, and the FY2 or CT is unauthorized to do this surgery, and the anesthetist keeping calling you to come and annoyed that you are late. So that's very, very good question. Guys, you need to get the priority right. So patient under anesthetic who is under anesthesia, general sleep is top priority. Yeah. So the ED patient, the ED consultant. So let's speak about this one, about the order of priority. Patient who is under, unless the patient is not asleep yet, but if it is sleep, this is your top priority. Yeah. So you should say, I will go to theater and this patient. But before that, I will do a few things. First of all, contact your consultant and ask him that there is a patient in A&E. This is a situation. I think this patient needs urgent, immediate assessment. And you will say that I know my consultant is far away. I will call the ED consultant, explain to him my situation, and ask him to see this patient and make sure that the patient will be safe, and inform him about the arrangement I made that my consultant on the way to see this patient. Yeah. So always don't leave patient under general anesthesia in theater. Yeah. And patient in ITU, if you got one patient in ED and patient in ITU is less priority. ED is top priority because we think ITU is monitor area. This is very important, Michael, what you said now. Let's say it again. General anesthesia patient sleep is top priority, and then ED after that, and then patient in the ITU. So if you got patient in the ward and patient in ITU, go to the patient in the ward first at top priority. But that doesn't mean that you will say, no, I'm going to the ITU and will just, after I finish, I will go to the ITU patient, go to the ward, and then, no. Show the examiner that you got plan. You are using the resources available around you. And then, for example, you, rather than not to go there, you can call them and give them initial plan. Can you do this while I'm sorting this patient? And trust me, your colleague will appreciate and respect you, because you show them what's going wrong with you. Now you have someone who's unwell on your hands, but this is your plan. That will give them confidence to look after your patient.
I think one thing,
Ajit,
is that I think this is not a very unusual scenario in real practice as well. I used to work in a small district hospital, so it is very common that you are doing an appendix and there is possible perforation or bowel obstruction sitting in A&E. So I think practically what you do is, if the patient is induced, obviously you will go ahead with the surgery, inform the consultant if patient is very unwell and they need to come in urgently. In the meantime, this is also a scenario where they want you to see your delegation skills. Okay, you're telling the ED colleague to do some stuff. Also, you can send your SHO or a core trainee who is with you to see the patient. And it is also important to say in the scenario to the interviewer that, okay, this looks like the patient is probably in perforation. Okay, I will ask my SHO to review this patient and give him specific instructions about resuscitation, proper imaging, and then get back to me in theaters what he thinks about, and then we can update the consultant in the meantime. So I think that is also very important. You can utilize and delegate stuff.
Exactly. Yeah. And please, guys, share with the examiner your thought. Like, for example, don't say I'm going to ask my consultant to see this patient. I'm going to see this patient. Start by showing them your situation awareness, that I'm very concerned about the ED consultant. He will have this and this, and if we didn't see him immediately, he might do this. And also on the same time, I'm concerned about the patient here because of this. Then I need to think of always these things. You need to say it loudly to the examiner. Show them that you're behaving as a team leader, that a registrar I can trust, because they are a consultant and they are looking for you as their registrar. And they want to see if I will be happy that this candidate will be my registrar overnight to look after my hospital while I'm at home. Show them this team leadership, saying that I'm concerned about all this stuff. So I need to think about the available resources. So one thing I can do is to do this one, speak to my consultant, ask him if he can help, and give an initial plan for ED consultant, as I just said. So this is, I think, a place for you to show leadership, to show team leadership, and also your skills, communication skills. And yeah, and in regard to the question from Apilash, she's saying appendicitis confirmed in News 8 versus ED trauma, patient unstable. What's the priority here? CT2, so I think if it is confirmed appendicitis, then I can give my CT2 very clear plan to see the patient with C-CRISP algorithm and ensure the patient keeps the patient fasting. And sepsis 6, as I just said, should be incorporated in the C-CRISP algorithm. And I will ask him to notify the theater, and then I will join the trauma case. Yeah. So always, if there is a very clear diagnosis, confirmed diagnosis, that will give you a bit of mind relief, and go for the uncertainty. Because from what your question, I think the ED trauma is unstable, but we don't know what's wrong with it. So I'll give priority.
And in sometimes in scenario where you think there is a trauma call and there is something where you need to be there, you can always say that, okay, because in reality, there will be 5 people looking after the trauma patient. And it is very rarely that you would be doing something very quickly in ED. Most of these patients will either have resuscitation and A to E assessment and a CT scan. So depending on the situation, you can always tune that, okay, there will be 5 people doing the trauma call, and this particular patient, suppose there's a bleeding patient in the ward which you need to see, you can always say, oh, I need to see this patient first. In the meantime, the trauma team or the ED trauma team would be looking after the patients in ED. This is a question which should we lead the trauma call? I don't think usually you do in any hospital, because it will be usually the ED consultant or ED registrar who leads the trauma call. You will be probably in your ward or doing your stuff, and they will call you or bleep you about a trauma call.
Yeah, but again, if you got that opportunity, show your leadership. And yeah, but most of the time, the ED consultant, although sometimes happen to me many times, they would be like fed up. It's like they got 4 or 5 trauma calls. They want you, can you lead this trauma? So just show your leadership. If I were you and got in the exam or in the interview, they ask me the patient in ED, for example, and everyone is busy around, I will say I will lead the team. Yeah. So
I think
take
many times we tend to overthink scenarios in our head, okay, which are many times not happening in practical world. But so don't get anxious by thinking scenarios like this. Also, in these scenarios, I think it is what it matters is that you show them a prioritization with a logical reasoning, which is more important than being irrational and not giving a plan. If you are being logical and you're showing them, okay, you're using all your resources, I think that is all what matters.
Lovely. That's good. Okay, let's go to the last station before the mock interview, and that will be the portfolio station. Okay, so portfolio station, guys, as you know, there is a scoring already done for your portfolio. So this station is just about seeing or assessing your portfolio from different aspects. They want to assess you, and do you sell yourself as the ST3 registrar, someone who's enthusiastic, got plan, looking forward for very successful career, someone who can benefit from the training program or no? And that's why they will take a snapshot of your portfolio. So it's always generic questions, and I will show you example in the next slide of what these generic questions looks like. Most of the time, they are either 3 or 4 questions. So my advice to you is practice portfolio station. And I will say it again, practice portfolio station. Unfortunately, in our team practice, we always tend to practice the clinical and the management scenario and leave the portfolio station to the end. But to be honest, this is a very easy station and it is a free score. So you should practice all these 3 stations together from now. Yeah. So make sure that you practice these generic questions and time it in 2.5 minutes for each question, just to make sure that in 10 minutes you'll be able to cover all these if they are 4. I don't think they will be more than 4. From my observation, it's never more than 4 questions. So as I said, it is all about selling yourself as a good ST3. So don't overestimate your situation and don't underscore your portfolio. Yeah, and always there is a structured answers, and you should make it very clear how to answer this generic question if I got it in the interview. And very important thing is be prepared to answer portfolio gaps and don't make things, because if the examiner felt like you are lying and he went behind that, then there will be, as you can see, you will see later on the feedback after each station, there will be a line down there. They're asking about the honesty and if there is any concern about the property of the patient, of the candidates. So if that happened, then you might be at risk of to be reported to the GMC, and that would be catastrophic. So my advice to you, be honest. And if you got gap in your portfolio, don't panic and just show them your plan and show them that you are aware with your limitation. What I mean by that, for example, if the question was, tell us about one publication you are most proud of, and you don't have any publication, and this is the gap in your portfolio. They expect you by this level to have publications. So don't lie. and don't make any publication from your mind, because they are examiners. They are very smart and clever. They will know that if you did this one, because they will go into details about what you did and what is the outcome, and they will be even interested to know the evidence you brought after this publication. So just show them that you are aware of this gap in your portfolio and you got plan. I remember in my interview, the examiner specifically asked me about lab colleague. He said, how many lab colleagues you did and what level? And at that time, when I applied for the interview, I was trust grade, etc. So no experience to doing like I haven't done lab call independently to say level 4 or so. So I said very clearly, I'm aware that I need to work on my number of lab calls, and I'm glad that to share with you the news that I've been upgraded to registrar last month, and I have spoken to my supervisor that I have done a good number of lab appendectomy. I need to upgrade my skills in lab quality, and have been assigned to attend one of the lists there. And I saw in the feedback, the examiner said he got very clear plan to improve his surgical skills. So he comment on my plan. He didn't he didn't mention that I don't have lab quality, but he said like he's someone who's aware with limitation and got plan to correct this gap in his portfolio. This I think is very important. So just look at this. I think the most generic questions that came over the last couple of years. Tell us about yourself was mainly operative skills. So this is a very big questions. They used to take a snapshot rather than the full portfolio in one question. So rather than to ask you, tell us about yourself, they will ask you about teaching. Tell us about your leadership experience. Tell us about your operative experience. And then they will ask you about the best audit, for example, you got on your list and publication. So you should think carefully about this question and how to answer them. Let me just give you example because of the time. If, for example, the question about audit, and before the interview, I want to assign one of my audit that will be the best audit I will speak about, if they ask me, then that audit, I believe, should have 4 criteria. Number 1, it should be the topic of the audit should be related to general surgery. Yeah. And number 2, it should be full cycle audit. And number 3 should be presented, like I have presented this audit somewhere, so that's good. So it's being made full cycle, presented. And number 4 is very important, if you can get that, is that the audit changed the practice in my environment. So after my audit, the department and the lead of the general surgery department agreed on making a pathway for diverticulitis, for example. So you changed your practice. So this will be the best audit, no debate. Yeah. Now the question will be how to present this audit, how to sell it as a good thing that will the examiner will be happy and give you 10 out of 10 in this question. So start by saying, I observe someone who's looking for gaps in the care at his trust and his hospital. And then you mentioned the gap in care, and I went and I checked on the available, for example, guidelines, and I found that the target should be this one. So you show them the international. And then the next step, I discussed that with my supervisor, and we thought it's a good opportunity for me to lead an audit. And then you start using the buzzword, the terms, leadership and management. Is a good opportunity for me to lead this audit, and also a good opportunity for me to teach my junior colleagues about performing audits and with this audit. And then you speak about the methodology. And please, guys, if you want to speak about publication or audit before the interview and during your practice, make sure that you'll be familiar with the numbers and outcome. Yeah. Because you want to show them that it's very generous thing. So always go and read about your audit. What are the findings? And then speak about the second cycle, what the change happened, and then speak about, I managed to present this case at this conference, and then I'm glad to see that this audit result in the formation of this pathway in my department. So I think this is the my way for presenting my best audit, for example. And then on the same way, you will make structure for all of these generic questions. It's not exhaustive list, definitely just example. There will be more, maybe Ajit will share with us. Over to you, Ajit.
So thank you, Nazar. I think portfolio station is a very important station because everyone tends to overlook this station because we are more worried about clinical and management. But keep it in mind that all three stations are of equal marks. Okay, all of them. I think they have 40 marks, all of them. So it's the same marks every station has. So don't think that they have. In fact, if you see overall structure, portfolio carries the maximum percentage of marks because they have assessed you in the portfolio shortlisting level, and they're also asking you of station out of portfolio. So portfolio has maximum marks. But if you are prepared, then probably you'll be slick. Practice is verbalize it. Okay, we always think that okay, we probably don't have a lot in our portfolio, but if you you know uh, deeply dissect your portfolio, all of you would have something or the other. And it's not that they want you to be Nobel Prize winners or receiving grants of 50,000 pounds from government and things like that. They just want you to be aware what you have done, and you are aware what you want to do. So like the gaps is very important because you will come up with, they will sort of highlight in your portfolio station that you have this gap. So be ready what you are prepared to do it. So like if you don't have a publication and you are involved in a publication or you are involved in a study, so tell them, okay, I don't have a publication, but I'm involved in this study who is looking after XYZ, and we are aiming to come up with a good publication out of this. So always be ready to tell how are you going to fill this gap. Also about the generic questions like what you tell about yourself or what have you added after the applications have closed. I think the common structure which everyone uses is the camp protocol. Sorry, camp structure where you tell them about your clinical skills, academic achievements, management station management and leadership qualities, and personal achievements. So I think if you dissect along or you prepare your answer as per this, it is more easy to remember. Also, there was sometimes we think that okay, we have probably worked in orthopedics previously, and I have a publication in orthopedics, but I don't have a publication in surgery. So I think it is good that if you have a publication in surgery and if you tell them, but if you don't have one, that does not matter because everyone knows that these days everyone is trying to get into any training number, whatever they can get. So it doesn't matter. What they want you to do see is that you are aware of research methodologies and how to do a research and what is research all about. Third thing is, I think if you see the handbook, the handbook which has come up this year and last year, there's been a drastic change from previous years is that they have not marked you guys for teaching and management or leadership skills because they used to do it in the past, and they have clearly said it in the handbook that they would assess you in the portfolio station. And from previous years, I can tell you it has been a consistent question where they will definitely ask you about your teaching or teaching and management. So I think these are two questions which you can definitely prepare for your portfolio station because they're clearly highlighted in the handbook. And the third question, which is very consistent in I think, is that what have you added after the portfolio? Because rest everything they have seen in your portfolio, they have marked, but these three things they don't know and they have not seen, they've not marked you. So be ready to prepare all at least these three questions thoroughly. And please guys don't lie because I hope you know that all these interviews which you are giving will be recorded, and they will, and when they send you the pre all the guidelines and thing, they will tell you that this is all recorded. So if you lie and they find out later on, you are in a big trouble rather than probably losing a couple of marks. And I think yes, that is all from my side.
Thank you so much, Ajit. I think we are running a little bit of
Yes, a lot, I
late in
think.
I
time.
just want to
Amira, you want
add
to
one
say
more
something?
connect.
Yeah,
I
please.
just want to add one more comment on that station, the portfolio station, is that actually the interviewers themselves, they haven't seen your portfolio, so they don't know you. So don't expect it's like you'll say something very quickly, and because they have seen your portfolio before, they haven't seen your portfolio. So you have to sell yourself, as Nazar said, okay, and tell them indeed as much as details or as quickly as you can to tell so they can know you, they know your capabilities, they know what you have achieved. And adding to what Ajit said about the question is like, what have you added since since you submitted your portfolio? I think they always ask about this question. So be prepared again. If you had like a presentation done, audit done, maybe your logbook got better. Any of these stuff matters. So just like put like practice what you're gonna say in these questions, but again, they haven't seen your portfolio. It's been marked, but these interviewer haven't seen that. So try and just sell yourself in a good way.
Yes, and they don't have a physical access to your portfolio, ISCP or physical copies. I think it used to happen previously, I think many years ago, when you went into the interview with proper physical copy and big, files, but they don't have it anymore. But don't think that they cannot check it. They can always counter check it. So don't lie, please.
Lovely. Yeah, thanks, Amira and Ajit. Yeah. So we'll just go through the questions quickly before we finalize the talk. What are the common questions for portfolio? We spoke about them, and Ajit as well remind you with what you and Amir as well. She said, "What have you added to your portfolio?" And that to show that you are someone who is continuously acting on his portfolio and himself, regardless he got interview or not. Yeah, and this is very important. What portfolio they use? I think Amir answered that question. They don't have access to your portfolio. They will just ask generic questions. Okay, what if I don't know how many or what level of lab quality? So my advice to you now, get familiar with your e-log book and see what numbers you have and what level you reach so far. And then the question will be, should we mention the number of WBS? I don't think you need to mention number, but if they ask you tell us about something, they will be very specific. Like, for example, they will ask your operative skills. So you don't need to go about the whole, but you speak about what they expect you to do. For example, you should speak about your lab appendix. And if you are independent now doing lab appendix, which they expect you to have, to be. So just mention that, and then speak about anything else you can do in the general surgery field as well. But no need. I don't think you need to mention number. Can you repeat the three questions we need to prepare for portfolio? So as I said, this is not an exhaustive list. This is not the only three questions, but I give you as an example. So what I said in my questions, let me go back. First of all, they might take snapshot of your portfolio rather than asking, tell us about yourself. They will ask you, tell us about your teaching experience, leadership experience, operative experience, or they might ask you about the best audit you have done or the best publication. Yeah, and they might ask you about anything you added to your portfolio after submitting your application. So these are the examples of questions that might come, but definitely this is not an exhaustive list, as I said. Going back,
I think we
yeah,
have answered
teaching.
most of these questions.
Yeah, I think we answered all of them. Yeah.
The only last question, I think Sidham has asked that, can we use a printed draft? So I think you don't have an access to any printed, you cannot read out of any printed material, in the question. You have to remember it, memorize it, and say it to them. You cannot open a Word file on your computer or have a printed paper in your hand. But it is obviously when you are preparing answers, prepare it well and memorize it. I think that's the only thing which you can do.
Lovely. So final thought, guys, is about how to prepare for the interview. I would say make your team. Don't practice alone. This is a very important. I think everyone will agree that you need to
Definitely.
practice with other candidates. Yeah, you want other candidate to comment. And by the way, I see most of us they practicing camera switch off, lying flat in his bed, and this is not it's not good. Always during practice, open your camera. Ask your colleague to comment if the camera like the wind is nice. Sometimes one of the consultants said in the interview we see like rubbish things. One of the candidate like half of his face is not on the on the screen, and the people they ignore this one. Definitely there is no score on these things, but you want to be perceived well or by the examiners that you look professional, someone who is familiar with Microsoft Team, using it more frequently, know how to prepare himself, how to present himself, and see, for example, the camera for Ajit. Nice. I can see all the aspects there, because sometimes the body language is very important. That will have impact on me as an examiner to see how the enthusiasm you are showing with when you are talking about your portfolio, and then the seriousness I can see on your face, the smile I can see. So all this is things matter, to be honest. So practice with your colleague. Use timer, please, guys. It's not about delivery of answer. It is about the timing of your answer, because sometimes they're very good candidate. They lose this opportunity because they just run out of time. So make sure that when you start practicing, there is a stopwatch there, 10 minutes, and then start your answer. Always my advice to you, use the same setting that you are using on the day of interview, because that will assess the sound. Your colleague might say, oh, this is not good place. The computer you are using, you want to check the audio, you want to check how clear is the camera itself, and also the background. Don't make anything that distracts the examiners. So always use the same settings. In regard to the internet, I will suggest using the cable, the Ethernet cable, rather than the Wi-Fi, because the Wi-Fi sometimes might just interrupt your meeting. It's a good practice to ask your consultant when you are in the coffee room. Ask him, can we just spend 10 minutes? I want to show you. I already got the scenario ready. I want to answer it and want your comment. This senior in front of you is the same one who will sit on the interview to assess you. So this is a good free opportunity for you to use. Yeah, and please, guys, you want to be relaxed. So if you can plan any study leave, do. Yeah, and attend courses, workshops like this one. And we are very glad to the Egyptian Society. They are providing this practice from the time I was practicing for the interview, and I think Ajit as well, he said that we are very grateful to them. Every week from now until the time of the interview, you got one of the senior people, they will come and sit down to moderate and assess your answer. So use this opportunity, and always practice mock interview. You want the real feeling of the interview. If you became aware of any mock interview anywhere, just subscribe to it. This is not an exhaustive list of resources, but yeah, I think this might help you as well beside the plan question. Thank you so much, guys. This is the talk about this preparation interview, and next will be our mock interview will be started and led by Ajit, and I will just share comment. This is my email. Feel free to contact me if you got any questions or anything I can help you with. Over to you.